Thanks very much. Thanks very much to the Bennett Institute for the opportunity to speak today. Delighted to be here. We had an amber wind weather warning yesterday, so really delighted to be here in one piece. I did get randomly allocated an extra row seat though, so that was quite nice. But yeah, I'm going to be speaking about evaluating policy impact on pain prescribing, learning from international experience. It's very much us learning from you, I will say, in terms of data infrastructure, but just share a little bit from the Irish perspective. Probably no need to give this background to the audience we have here today, and I know we've already had a number of talks focusing on opioid prescribing, but medication harm as both a national priority in many countries and international priority as designated by the WHO currently. Controlled drugs as one, I suppose, focus area for reducing medication harm, opioids being one particular priority target. And despite concerning evidence from other jurisdictions, we had an essentially complete lack of information from Ireland in terms of utilisation patterns for opioids over time up until quite recently. Our National Health Funder, kind of the equivalent of the NIHR, launched a funding call for secondary data analysis projects back in the run-up to 2020 to try and use existing data sources to answer relevant policy or practice questions and or to develop tools to help use existing data sources. I mentioned this is the work or the scheme that funded the project I'm going to present. It's interesting that our health funder is trying to promote use of secondary use of data because this is an OECD figure of the extent of health data sharing intensity from 2020. And if you're looking for Ireland, we're right there where there's no bar because there is essentially zero data sharing intensity as of 2020. It has improved somewhat since then, but only very slightly. So that's kind of the context, population of about 5 million. We've about 1/3 with public health cover and good capture of prescribing or prescribed, dispensed, claimed for and reimbursed medicines from pharmacies. And as said, health data availability is poor. So in that context, we set out to try and evaluate prescribing of controlled drugs. Going to present work on pain medicines here. We have also done some work around benzodiazepine and related sedative agents, characterising time trends and looking at the impact of policy changes. One of the co-investigators on the project was Brian McKenna from the Bennett Institute. So we did look at a cross-country comparison between Ireland and England as part of the project. We've our protocol published from a few years ago available at the QR code, and I have a couple of other QR codes if you're interested in reading any of the publications. We used a variety of kind of approaches across different studies, cross-sectional or interrupted time series analyses, looking at the period of 2014 up to 2022. We requested data from our kind of National Health Service body, kind of equivalent of the NHS BSA. They did take about 2 years in total to provide the data we requested for our 2.5-year project, which was interesting. But we also very much took advantage of the open data available from NHS BSA and pulled into open prescribing as part of the project. In terms of the medications we looked at, opioids as well as other medicines used for pain, anti-inflammatories, paracetamol, and lidocaine plasters that I'm going to come back to in a couple of slides. And for the purposes of the presentation today, we were looking at essentially kind of volume measures of use. So rates of prescriptions dispense, costs, and oral morphine equivalents or defined daily doses. The first bit of work was really just to say, well, what has happened over this time period where we don't really know. So we looked at trends in analgesia prescribing over this period in Ireland and England. And what I should say is this is looking at the publicly covered individuals in Ireland. About 1/3 of the population, it does skew towards the older population and those on lower incomes. Higher levels of deprivation, as we've already heard this afternoon, higher levels of comorbidity conditions, painful conditions, and expected higher use of analgesics. What we found for Ireland over this time period, in the blue, opioid dispensing rates increased by about 25%. We saw growth as well in paracetamol use. We saw growth in gabapentinoids use, which I'm not going to focus on too much. And when we compare that to the full population in England, all of the lines are in a different part of the graph, so that's your first indication something might be different. And what we saw was about a 19% reduction in opioid use over this time period, as well as kind of the two other most common drug classes. So I suppose it aligns very much with the time when the Public Health England review and lots of the opioid stewardship work, many examples we've already had described this morning, would have come in and seen those kind of fruits, bearing fruits, whereas in Ireland we have not had any similar kind of opioid stewardship policy focus across the health system. And yeah, when we compared these prescribing rate or dispensing rates across the two countries, we very much saw it going from a kind of 40% higher rate of opioids to over 2 times higher by the end of the study period. The other thing we looked at as far as this project was looking at the impact of policy change on use of analgesic medicines. Low-value care is a challenge for all health systems in terms of sustainability. And lidocaine plasters are one example of this, licensed for post-herpetic neuralgia, essentially for post-herpes infection, neuropathic pain that can develop, used in other forms of neuropathic pain, but I suppose no further evidence to support benefit. And we essentially had this kind of natural experiment that in Ireland we introduced a restriction on reimbursement of this medicine back in 2017, that essentially a prescriber had to apply for permission to have this medicine reimbursed for individual patients on a patient-by-patient basis, whereas in England there was the NHS guidance on medicines not to be routinely prescribed in primary care, which did include lidocaine plasters as one of the measures there. Again, a graph that you probably don't need statistics to see what happened. In Ireland, we had prescribing fall off a cliff, essentially. We looked at this interrupted time series that I'm not showing that here, but about a 97% immediate reduction in prescribing, and then also a small trend change post that introduction of the reimbursement restriction. In England, a much more modest reduction immediately following publication of that guidance, and yeah, a trend change afterwards, that a tail off in that medicine being used. I've done a sneaky thing. I've put different axes for the two countries, and you might have noticed that on the left-hand side we have the Irish axis, the right-hand side for England. Prescribing in Ireland was about 30 times higher rate before this intervention was introduced. Even if all of the people we were missing from our data, private prescriptions, even if none of them used this medicine, there would still be many-fold higher prescribing in Ireland. Even after this very restrictive policy was introduced, we still have higher prescribing compared to England. So there is a possibility some patients may have switched to paying for this privately. These plasters cost in excess of kind of probably about £100 per month. For people who are eligible for this scheme, probably don't have the means to be paying for this. We're looking at some of the unintended consequences of the Irish policy change, what happened to those patients in terms of their other pain medications, and early analysis shows very much intensification of things like opioids and anti-inflammatories following this policy change. Just to finish off, the last bit I mentioned in terms of that funding scheme was trying to develop tools that can make data more accessible. We do have open data in Ireland. We have open data from our health service on the top 100 drugs by volume and cost every month. So if you're interested in any of the top 100 drugs, and they remain one of the top 100 drugs on a consistent basis, you can use that data for interesting purposes. If you're interested in any other medicine beyond those top 100, it's not all that useful. These were static monthly tables that have been available back from 2019 onwards, but we developed a relatively simple tool. It's not 7 gigabytes of data per month. It is, slightly less than 200 rows, pulled into a Shiny application that allows visualization of trends in use. So I was going to do a live demo, but again, won't chance it. If you want to visit the QR code here, it brings you to the tool called RX Trends. You can type in a medicine. Again, if it's in the top 100, it'll be there. If it's not, it won't be. Yeah, you can get, relatively simple trends over time for different medicines. So to conclude, seeing rising opioid use in Ireland relative to England, highlighting the need for structured review and interventions in Ireland. We've seen, I suppose, yeah, as I said, what's happened in more recent years following Public Health England review in England. Measures to reduce low-value prescribing of lidocaine plasters have divergent effects, and obviously considering unintended consequences being really important. Our open medicines data in Ireland is a bit like a exit row seat during an orange weather warning. It's good to have it, but at the same time, there's lots of limitations. So it covers few medicines. It's at drug ingredient level only. We can't look at specific products. It's also aggregated nationally, so we don't know what is happening regionally, locally, or at practice level. We're currently engaging with stakeholders, national agencies, to try and push for expansion of the data that's made openly available in order to try and drive some of the improvements that we've seen presented here this afternoon. Thanks very much for your attention. Cheers.